should ARNI be started in acute decompensated heart failure? When should it be started? Pre-discharge or at follow-up? And what are the precautions that we should be taking for such patients? So the newer strategy, as told to us by the Pioneer SF study design, this study involved 881 patients hospitalized with acute decompensated heart failure, EF less than 40. They were stabilized on standard treatment like inotropes, diuretics, oxygen, bed rest, etc. And once they were stabilized and once they had achieved a systolic BP of more than 100 for 6 hours, no symptomatic drop in BP, no increase in IV diuretics, no IV vasodilator increase, and no inotropes in the last 24 hours. Such patients were subjected to start sacubitril valsartan or enalapril. And this was a pretty stiff dose. Target dose, of course, was 200 BD. The starting dose was left at the discretion of the physician. This was started in hospital. And this was a blinded study, duration of 8 weeks, looking at acute parameters change. So this was a study which relied more on improvement in laboratory parameters rather than clinical outcomes. So this was, you can say, is probably a hypothesis generating study. And let's see what it showed. So what they evaluated was NT-proBNP, whether these drugs could be safely tolerated, and what were some of the early clinical outcomes. So what we find is that early clinical benefit of ARNI in ADHF was very evident. The NT-proBNP, which is a surrogate marker for reduction in heart failure, significantly improved with sacubitril valsartan. And in the short term, say 8 weeks, the people on ARNI showed a less CV deaths or rehospitalization for it. So definitely when you have an acutely decompensated heart failure patient, you can start them once they are stable off IV diuretics, off IV inotropes, off vasodilators, and with no drop in BP and BP remaining at 100, you can start them on inside the hospital. You can start them on ARNIs and with expecting good results. And this was the result of the 8-week Pioneer HF study. When you look at the pre-specified subgroup analysis, we know we can see that all those patients who had come in heart failure acutely, many of them were de novo heart failure patients. They also improved better with ARNI rather than with enalapril. Chronic heart failure who had worsened also improved more with ARNI. Those who were taking ACE inhibitors, ARBs, versus those who were not taking ACE inhibitors, all these patients improved better with sacubitril valsartan. So across the board, de novo heart failure, worsening heart failure, those with or without ACE ARBs, all of them benefited by changing over to sacubitril valsartan. And I mean, if you look at the study of patients who were without prior ACE-ARB exposures, they also improved significantly in terms of change in NT-proBNP and hospitalization.